All right. Just a couple other housekeeping items before we get started with roll call. A reminder that this video is being recorded. Everything said and shared as part of this recording will be posted to the ADHS YouTube channel. If you are joining by phone, you may need to hit *6 to unmute yourself. Because most of you are virtual, we just have one public member here in the room. Thank you for being here. Please identify yourself by name if you are speaking so we can make sure we capture your name for the meeting minutes. We'll go ahead and do roll call. Shelley?
All right. Andrew Tang.
Present.
Anthony Griffey. Or Tony Griffey. Brent Burgett. Charles Hu.
Here.
Chris DeChamp.
Present in the room.
Clifford Jones. David Natrika.
Here.
Debbie Johnston.
Here.
Bronco Castro Marin. Gail Bradley.
Present.
Garth Gamer.
Present.
Herman Butler. Iman Feiserfen. Judy Baum. Melissa Anderson.
Present.
Neil Williamson. Nurse Patel. Philip Johnson. Rod Reed. Sandy Nygaard.
Present.
Sean Bowker.
Present.
Tara Johnson. Tara, we see you listed. Let's do a mic check. You might need to hit *6 on a phone pad if you're using a phone.
I think it started out for Tara.
Oh, she's raising her hand.
All right, we have your attendance, Tara. Thank you.
And Vicki Bennett. 1, 2, 3. We have 11. We need 13 for quorum.
All right, bear with us just a couple more minutes. We are going to see if we can get at least 2 more people on the line so we can get quorum. minutes. Should get one more in there.
Hey, Dr. Jones, we were expecting you on the staff meeting today. If you could visit your calendar and join that meeting. That'd be helpful. Thank you, bye.
No, Dr. Jones. Dr. Jones just joined. Oh. All right, looks like we need one more person for quorum. They are joining right now, so I think we are gonna be good to go.
Shelley, we were hoping to join the staff meeting. Thank you, bye.
All right, it looks like we have two more that just, joined the meeting. If we could just get confirmation, of your presence. Thank you. Dr. Jones, we see that you joined. Oh, just lost reception. Let's see, I know, Chief Forget, I saw that you joined.
Hello.
Thank you. And, Dr. Jones?
Hello.
Excellent. Thank you so much. All right. Thank you, everyone. We do have quorum. We will go ahead and officially get started with the meeting now. The first and main item for the discussion today is to discuss, amend, and approve the ACS field triage guideline update. If I can get a motion to discuss, please.
Motion.
Second.
I think I was at Dr. Jones for first and Sean for a second.
Yes.
Yes.
Thank you. All right, Shelley, if you can go ahead and open the PowerPoint for me, that would be great. Thank you. So thank you for everyone participating today. If you can go to presenter mode there, so it's a little bigger screen. I'm going to share kind of a combined PowerPoint slide set that combines slides from both the ACS field triage guideline presentation that ACS has put together as kind of a free resource that states and entities can use, as well as some additional information that I wanted to make sure we share with this committee. So I'm going to run through these slides pretty quickly, and then hopefully that will help guide some of our conversation. Next slide, please. So again, this was produced by ACS. They have really tried to put together a set training curriculum as kind of the background for this update. They are using this to do their own presentations when they present around the country to different organizations. Last week at NASEMSO, so the National Association of State EMS Officials Conference, the ACS representations used this PowerPoint as well as part of their presentation. Next slide. So a little bit about the history and the process. The last update to the field triage guideline was in 2011. For this revision, they really wanted to focus on end user feedback, and the end user being EMS, EMS agencies, EMS providers, as well as EMS medical directors. And so that was who they used to get the feedback to make the changes initially. This was funded and supported by NHTSA, and the review process had really three steps. The first was a steering committee that met for 2 years before the National Expert Panel met. Then the National Expert Panel convened, and they had 12 national organizations that were a part of this review process. So why a guideline? Next slide, please. So really, I can scroll through my computer. So the main goal is to get the right patient to the right place at the right time. So the hope is that we make sure that we get the right trauma patients to the right level of trauma center when it's appropriate. We also want to minimize variation in destination decisions. So for many people throughout Arizona, they have multiple different hospitals that they may transport patients to. We want them to be as consistent as possible. Sorry, I'm just doing a little shuffling of the feet here so I can use Shelley's computer. So there's a lot of new research that has come out. So if we think about medicine, and the last update was in 2011, and so this update is now over 10 years later. So significant things have changed since that time frame. And we really want to reduce the time of variation in making decisions, and there's a lot of opportunity to reduce both under triage and over triage. So for many of you, those terms are very familiar, but really what we're talking about is under triage as a percent of seriously injured patients that are missed by a field triage process. So that means someone who has significant injury that's not taken to a trauma center. And over triage is going to be a patient that was maybe deemed to be sicker or more injured than they actually were and went to a trauma center unnecessarily. So there was a lot of EMS input in this process. So they sent a survey out to 29 national organizations representing EMS and trauma. And hopefully many of you participated in that survey. I know that I did receive the survey from multiple different organizations and did take some time to provide feedback to the process. So they had just under 4,000 responses. And again, these are really specific EMS and trauma responses to the survey. They brought together an interdisciplinary national expert panel, and they did a systematic review of EMS field triage and other relevant published literature. So this was a really rigorous process for adding and removing criteria. So what that means is they looked at each step in the initial 2011 version, and they went line by line and said, is there data to support this? Should we continue this process? Does it need to be changed, or is this good enough? So I wanted to share a few articles here. So this is one article that was published as a part of this update. So this is the National Trauma Triage Protocol, how EMS perspective can inform the guideline revision. There is a link if anyone is interested in finding this. It's free to download. But this is really important because what they're doing is saying, you want to look at EMS perspective. So the feedback from EMS and take that to make changes to a guideline. This is one of the many published articles that has come out with this guideline update. As part of this update, they did 5 systematic reviews, and the reviews included looking at motor GCS versus the total GCS. They looked at out-of-hospital circulatory measures, out-of-hospital respiratory measures, mechanism of injury and special considerations, and overall guideline performance. So we're going to show this in a bigger format, but this is kind of what's new. So it's really changing that it's not an algorithm. They wanted to align this better with how EMS actually approaches a scene. And as we go through each step, that will make more sense. And really the goal was to get the patient to the right destination and make the decision faster. So the flow for this is from left to right and from top to bottom. So if you look at the guidelines, you're looking at your highest risk criteria are going to be your top left, then you're going to move to your top right, and then as you move down, you have a lower likelihood for serious injury. The reason this is important is when we get to things like EMS judgment, these are things that are important to consider, but they have a lower likelihood of serious injury, and that's why they're under the EMS judgment section. So as you see things that were moved to different sections, the rationale for that movement is based on that data. So this is our high-risk criteria. So if you look at this category, you've got your injury pattern, and the reason this was changed was feedback from EMS providers. EMS providers said, the first thing we do when we get on scene is you don't get a blood pressure right away. What we're doing is we walk up to a patient, and we see that they may have an obvious injury. They may have a penetrating wound, so they've got a gunshot wound to the chest. We're seeing that before we're getting a kind of vital sign. And so they wanted to really take the injury pattern and say, you know what, if you have this injury pattern, we know that these are significant injuries, that's already putting you in the top bucket for your highest level trauma center. They then moved to mental status and vital sign changes. And so this is where we see quite a bit of changes that will require some education to the EMS community. So we look at things like the motor GCS, so unable to follow commands. This is a much simplified version of the GCS score. They also broke down the blood pressure into different age categories. And you can see that patients that are over 65, they have a modified shock index. So a really easy way to calculate this in the field. So again, the injury patterns, kind of looking at some things that were added, they did include active bleeding requiring a tourniquet or wound packing with continuous pressure. Again, this was very much evidence-based. They have significant data from the civilian literature now to support that if a there's significant bleeding requiring a tourniquet or wound packing, that those patients have significant injury. So again, this is one of the evidence-based changes that were made. Some of this is just some rewording, so these aren't necessarily changed, but they've reworded it for some clarity. So again, things that were hopefully clarified in the updated verbiage, but not necessarily a changed criteria amongst the injury pattern. So again, mental status and vital signs. So you can see here the blood pressure differences. So again, the main thing to keep in mind is that if the heart rate is greater than your systolic blood pressure, there's a good chance that you may have a significant injury. The other part to look at is respiratory distress or need for respiratory support. So this is a simplified version. Rather than necessarily only looking at a respiratory rate, it's probably helpful for the EMS provider to say, you know what, this person's in respiratory distress, I'm needing to bag them or provide some other airway intervention. The other thing that they looked at was a room or air pulse ox less than 90%. And so really the feedback for this was that if a patient with a traumatic injury had a pulse ox less than 90%, the data shows that this is predictive of a significant injury. A big change that will require some training as it gets rolled out amongst the EMS community is the GCS score. This is something that GCS score in the field is pretty hard to calculate. It's hard to calculate in the trauma bay as well. But if you think about just simply saying unable to follow commands, which equals GCS less than 6, that's pretty easy and would put you into the high risk category. So next I want to show a couple pages from an article. Again, this is available if you want to Google search this. This is downloadable for free. So this is another article that was published in conjunction with these updates, which is Mechanism of Injury and Special Considerations as Predictive of Serious Injury and Systematic Review. So basically what this is a summary of all the changes regarding mechanism of injury and special considerations as they made these updates to the guidelines. So the yellow criteria is moderate risk for serious injury. So again, your red criteria was high risk, your yellow is moderate risk for serious injury. And so when we go to each section, you'll see at the bottom here, if patients meeting any of the yellow criteria who do not meet red criteria should be preferentially transported to a trauma center, as available within the geographic constraints of the regional trauma system. I'm pointing that out to you because that is not different verbiage, that's the same verbiage that has been on the guidelines for over a decade. So again, mechanism of injury, these are the things that are considered higher risk. So this was classically your box 3 on the older version. So you've got your high risk auto crash, things that are component with that. A big addition is your children 0 to 9, unrestrained or an unsecured child safety seat. They have also clarified that extrication relates to entrapment, not simply confinement. So if you do need to extricate the patient, that would be a higher risk finding as well. And then another clarification was rider separated from transport vehicle with significant impact, motorcycle, ATV, or horse. I don't think many of us think of a horse as a transport vehicle, but really what they're trying to say is that if you're on anything going fast and you get thrown off, you have a higher risk of injury. Anyone who's worked at a trauma center that gets patients who get thrown from a horse can attest to that. Many of these patients have significant injury. And so they wanted to clarify this to say it's not simply a motorcycle. Whatever you're riding, if you get thrown off, there is a risk for injury. Pedestrian bicycle thrown over, run over, or with significant impact. Again, this is some rewording and clarification. And then the biggest change is really fall from height greater than 10 feet, all ages. And this was based on, again, some of the data and many of the data that was supported in one of the attachments that Shelley sent out to you. So a lot of literature that really supported that falls from greater than 10 feet, regardless of the age of the patient, really was associated with significant injury. This is just a screenshot. So at the bottom, there is a hyperlink. Again, if you go to the ACS Field Triage Guideline website, they have links to all of these articles as well. But they talk about EMS Medical Services Judgment. And this is what replaced special considerations. So box 4 used to read special considerations. This is now considered EMS Judgment. And basically the summary of this is that the criteria in this section generally have less evidence and lower selective utility, but remain important consideration in field triage. And so that's really the key thing, is to say we don't have evidence to say that this should be in the mechanism of injury category, but we do know that all of these things can be associated with injury, and it's really up to EMS to look at the totality of the scene in the patient and making that determination. So now let's look at the EMS judgment. This is, I think, where we had the most conversation at the last meeting. So some things that are on here is that we see that the lower level falls in young children, less than or equal to 5, or older adults greater than or equal to 65, with significant head impact. We'll go into that in another slide a little bit more, in a little bit more detail. The other big change is anticoagulant use. So this is being clarified. This is for all trauma and not just head injuries any longer. So it's something just to consider, depending on the patient and the mechanism of injury. If they're on a blood thinner, so they have an anticoagulant and they have an injury, they may be more likely to have a significant injury or bleeding. So taking that into consideration. Suspicion of child abuse, special high resource healthcare needs. So again, this was a kind of a summary statement on their anticoagulation use. And really what they looked at is that there isn't great data one way or the other. And so I know a lot of people have very strong feelings on this, but if you go to the actual article and you read the data, so when they looked at multiple different articles, they pulled those studies together. They said some research suggests that such criteria could help identify older adults with intracranial hemorrhage, but other studies show otherwise. In a prospective study of older adults transported by EMS, the incidence of brain hemorrhage was similar to patients taking versus not taking anticoagulants. So based on these data, the panel felt that anticoagulant use, including antiplatelet agents, was best considered in the context of EMS judgment. So really what they're saying is, in the summary of the data, I know this is a big discussion piece, these patients certainly could have injury, but many of them don't have injury. And so it's up to the EMS provider to make a judgment. And that judgment is going to be when you're on scene and a patient's fallen and hits their head, do they have a head left and there's a ton of blood all over the floor? So that might be something that indicates that this patient had a more significant injury, or maybe their blood is too thin, like they're over anticoagulated. So some things to think about. So this is really that EMS judgment part, which is so critical. So what was the rationale for still including this in trauma considerations trio? And really what they said is evidence is clear that if a patient has an injury, then the bleeding from the injury will be worse if the patient is on anticoagulation. And that makes sense, right? So if someone has a head bleed and they're on blood thinners, their head bleed is likely to be worse. Similarly, if someone has a splenic laceration and they're on blood thinners, again, they're more likely to have bleeding. And so for this reason, the decision was made to keep anticoagulation use as an EMS judgment factor. But this is also why it was not put under mechanism of injury. So again, this is kind of in your lowest risk category. So next is low-level fall. Sorry, I don't know why hieroglyphics got into there, and this is important. But this is really talking about low-level falls. And what we're referring, I think, most to is going to be our elderly adults greater than 55 with a ground-level fall. And when you look at the data, what they really found is that ground-level falls are very common and non-specific for injury. And that's the key piece. So we see a ton of elderly patients that fall. This is non-specific for serious injury, and this was moved from special consideration to EMS judgment. And the reason for this is we really want you guys in the field to look at the patient and identify things. And I think EMS does a very good job with this. You may look at someone who had a ground level fall, but they have an angulated displaced ankle fracture and they hit their head and they've got significant bleeding from a laceration. This may be someone with a ground level fall that's a higher risk individual. You would contrast that to someone who maybe had a ground level fall, they were able to get up on their own, but someone called 911 to have them checked out. So again, just looking at each individual patient, and this is where there really needs to be that EMS judgment. And one of the key things that's outlined in this update is that EMS providers must, quote, judge significant head impact. And so I know that this can be sometimes difficult to determine, but I think EMS providers can and have actually done a very good job of this historically. I see very well documented in many run sheets. If someone has a significant hematoma, they have a large laceration, there's other clinical findings to indicate that the patient has significant impact to their head. So applying the guidelines. So really what ACS said was they appreciate and understand the context. They wanted to make sure that as each state looked at this, that each state and EMS agency knows their local and regional trauma resources. So we are fortunate in Arizona that we have a very robust trauma system. We have a number of level 1 trauma centers. We also have a number of level 3 and 4 trauma centers. Many other states do not have that same supply of trauma centers available. And so this does factor into your decision when you decide how and where you're going to take patients to. They encourage adoption by local and state EMS agencies, and they really said you need to educate and train in this. The other key piece, and I think this was brought up at the last meeting, was that we really want agencies and states to track use and outcomes through performance improvement. So much like this update was based on data, we really want to hopefully adopt this version and say, okay, now that we have a new standard, let's look at outcomes. Let's see if we see an improvement or any changes. So I wanted to touch briefly about transport and destination decisions. So each risk category that you see, so the high risk, which is your red, and the moderate risk, which is your yellow category, is linked with a transport recommendation. And these transport recommendations have not changed. These were on there before. It's not a requirement, but it should be used to inform the EMS decision on destination decisions. And so what that means is for an EMS agency, depending on what your transport times are, you may decide, based on the patient, you know what, if EMS Judgment, they have some risk factors, but they overall don't meet any of the high-risk criteria, I'm going to take them to our closest trauma center, which is a level 4 or a level 3, because transport to a level 1 would be an hour transport. That would be a very reasonable decision in that scenario. So again, this is going to be up to each agency to really provide training on that. The field triage guideline is designed to help EMS identify patients who should go to a trauma center. So again, recognizing that even level 3s and 4s, people often think of a trauma center as just, quote, the level 1, but level 3s and 4s are held to a standard to be able to identify, manage, and stabilize lower acuity trauma patients as well. And so we want to make sure that we help EMS identify those patients and get them to definitive care. One of the key pieces of this is that this process, the field triage guideline, is not meant to dictate how trauma teams are activated. So much like the old trauma triage protocol that was in place, this is really to help EMS triage patients. It's up to the trauma center to decide how they are going to activate their own internal trauma teams. We recognize that each hospital system, and even within hospital systems, there's different activation criteria. And so this EMS process is not meant to change that at all. So in summary, this update process was really inclusive of EMS clinician input. And honestly, almost 4,000 responses to a survey is a very good response rate. The new guideline aligns the information flow to EMS and how assessments occur in the scene. So again, this was the movement of identifying your injury up front and then going to vital signs followed by other criteria. The guideline is best assessed for impact of over and under triage rate. So what this means as ACS continues to do their site visits on trauma centers moving forward, they really will be able to assess how these guidelines are affecting under and over triage rates. I'm going to go ahead and just project this. I know Shelley has shared all these links for the ACS website. If you have difficulty to enter the links, just do an internet search for ACS Field Triage Guidelines. You'll come up to their website, and there are significant resources available, as well as links to all those articles as well. So that is a little bit of background. Again, thank you for giving me some time to go through that. I thought that was important, just because I know not a lot of people had time to research this before at the last meeting. All right. Okay, so with that in place, I will go ahead and open it up for discussion.
Hey, Dr. Bradley, this is Andy from Tucson. I think it makes sense to make the triage process consistent amongst agencies. My question is, do you have any insight into how the data on over and under triage is going to be tracked?
So, I think it's a combination of two factors. One factor is that ACS plans, and like they typically do in their ACS visits, collecting that data. So they definitely do collect that data as part of their site visits for trauma centers. The other component as well is that each individual trauma center can also track this. I know that many do already track this individually. So kind of two options, both ATS as well as individual trauma centers.
So,
Thank
and then I'll add that there was I've seen a couple of nice papers looking at a different metric. So ACS tracks ISS greater than 15 and assumes that if they weren't activated, that it was under triage. There are actually a couple of new systems coming that are being presented academically that look at the need for resources. So patient, was the patient transfused? Were they taken to the ICU? Did they go to the operating room? Did they have a procedure in the emergency department that actually may turn out to be a better way to decide who's under triage? But yeah, that's going in the future. Hopefully they'll move in that direction.
Yeah, I know we track it on our individual level in our own centers. I just wonder if there is a centralized process because, you know, this is a national guideline. I just wonder if there's a national process in place for tracking this. Thank you so much.
Thank you both. You know, I did also want to mention, since our last meeting, we also did get some endorsements from a couple of some agencies or entities here within Arizona. So the Arizona chapter of the American College of Surgeons Committee on Trauma formally endorsed STAB, hopefully adopting this update as written. In addition, Arizona Trauma Association also endorses updating this, and Banner Health Trauma System has also endorsed updating, hopefully STAB adopting this. So, you know, three large entities in Arizona that take care of many of our trauma patients who really are hopefully endorsing STAB's adoption of the ASTR field triage guidelines as presented.
Do you need a motion or?
You know, certainly we have a motion to discuss, amend, and approve on the floor. So if there's no further discussion, we can take a motion to approve unless there's further discussion that the group would like to have.
This is Sean. I move to approve.
Dave Notrika, second.
Thank you, Sean. Thank you, Dave. All right. We'll go ahead and take a vote then at this point. I will start with any opposed to approving the American College of Surgeons Field Triage Guideline update. Please say nay. Hearing none, any abstentions? All those in favor, if you could please write in the chat just your yay so we can make sure we get an accurate count, that would be appreciated. We've got a train going by. I believe I see Brent and Tara both have their hands up. Is that for approval?
That's support approval. I'm on my phone, so I can't type it in.
Thank you, Brent. All right. I think we have enough votes to approve them. And then Brent as well. All right. Dr. Jones, are you able to weigh in for a vote? Dr. Jones, are you able to weigh in for a vote? Oh,
Sorry,
I
no,
see
yeah.
it. All right, perfect. All right. Thank you. That is, the motion is approved then, so I think that is hopefully a brief and short meeting. We wanted to make sure that we had enough time for everyone to have their discussion. So we will move this on to Medical Direction Commission for hopeful approval and adoption into the TTTGs for the 2023 year. Again, any of the links, they are in the meeting invite, and if you have difficulty with any of the hyperlinks, you can just go to the ACS field triage guideline. If you search that, you will be able to locate all of these resources.
We're gonna go to a different room for the doctor.
Yep, and we will share my presentation as well. That was requested as too, so we can definitely share that.
Thank you. Nicely done.
All right, meeting is adjourned. Thank you very much.
Thank you.
Thank you.
All the meetings went that quickly.
I know.
Kind of smoothly.
I was like, I'm gonna have to kill them with data on this one.
Shelley, are we gonna drop off now?